Thank you, Laura, and welcome everyone. We're going to talk about ultrasound today. We'll start with ultrasound guidelines. All diagnostic ultrasound examinations require permanently recorded images with measurements when such measurements are clinically indicated. The only ones that don't are those eye ultrasound codes that are in the CPT book. Images must be permanently stored in one of the following media: printed pictures, film, or in the packs. Use of ultrasound without thorough evaluation of organ or organs or anatomic region, image documentation, and a final written report is not separately reportable. Ultrasound guidance procedures also require permanently recorded images of the site to be localized and a documented description of the localization process. They can't just say ultrasound guidance was used. They should describe the process of the ultrasound guidance, where they went in, etc. in the report. This can be documented either within the report of the procedure or a separate report. Usually it's within the report of the procedure. The CPT book also notes the following: that all imaging guidance codes require image documentation in the patient record and description of imaging guidance in the procedure report. So it's not just that's not just me. You need to make sure your doctors know that they need to describe the imaging guidance in the procedure report. Many ultrasound codes make a distinction between limited and complete. If the CPT book says if less than the required elements for a complete exam are reported, e.g. limited number of organs or limited portion of the region evaluated, the limited code for that anatomic region should be used once per exam session. The required elements are listed either in the code description or in guidelines within the CPT book, which is one reason why it's really very important for you to have a current CPT book. You may have heard me say this before, but I had a coder at a previous job who consistently coded the abdominal ultrasound wrong. She coded a complete when it was a limited exam, and I kept having to change it. And finally, what we came up with, she didn't have a CPT book from the AMA. She had a book from a different publisher that is supposed to be used along with the CPT book, but she didn't have the CPT book. This other book did not have the guidelines for abdominal ultrasound and other ultrasounds. It did not list the required elements. So she was going by the code description and thought that she had a complete ultrasound when she didn't. And this went on for months before we finally figured out what the problem was. So it's really very important that you have a current CPT book with the official guidelines for not just ultrasound, but for other procedures as well. You can't code a limited and a complete exam of the same anatomic area for the same session, and you can't report the limited ultrasound code more than one time for an anatomic area. For complete ultrasound exams, each of the required elements must be imaged and documented, or the radiologist must document why an element cannot be seen. Within the complete abdominal ultrasound, for instance, if the radiologist dictates within his report that the gallbladder has been removed, then you can count the gallbladder as one of the documented elements. The radiologist doesn't mention the absence of the gallbladder or just says gallbladder not seen, then you would code a limited exam because he did not the gallbladder is a required element, and the doctor did not document why it could not be seen. Sometimes he doesn't have to say the gallbladder has been removed specifically. He can say the patient is status post cholecystectomy, which would tell you that the gallbladder has been removed. So as long as it's documented, then you can count that element. If they don't document why it could not be seen, then you don't count it and you end up with a limited exam. Examples of limited codes in the ultrasound section, the 70,000 section, are the breast 76642, the abdomen is 76705, retroperitoneum is 76775, OB 76815, non-OB because ultrasound is 76857, and extremity is 76882. We're going to talk about these, but we just wanted to list them. The non-invasive vascular CPT code, limited CPT codes, 93882 for the cerebral vascular duplex, 93888 transcranial Doppler, 93922 for the physiologic vascular arterial extremity, 93926 for the duplex of the lower extremity arteries, 93931 for the duplex of the upper extremity arteries, 93971 for duplex of the venous extremities, and that can be either upper or lower, 93976 for the arterial inflow and venous outflow of the abdominal, pelvic, scrotal contents, and or retroperitoneal organs, and then 93979 for a duplex scan of the aorta, inferior vena cava, the iliac vasculature or bypass grafts, and 93981 for a duplex of the penile vessels. The required, when we say required elements, we mean just that. Those are the elements that are required for that exam. You might see other elements. The doctor may document other elements other than those required elements. Those are included if you do. You don't code a separate limited exam for those other elements. We see this most often in the abdominal ultrasound when they add a hernia or when they add for an appendix, etc. Those are not coded separately as a limited ultrasound with a complete ultrasound. Those are included in the complete ultrasound. So we'll start with abdominal ultrasound. 76700, again, is the complete. 76705 is the limited. The definition of limited hasn't changed in years, and for those people who don't have the CPT book and don't have the complete guidelines, that definition where it says limited, e.g. single organ or quadrant or follow-up, has caused a lot of problems because coders think that if there's two organs, then that makes a complete, or if there are two quadrants documented, that makes a complete, and that's not true. Since 2005, we have had these required elements for a complete ultrasound, and you have to have all of those elements before it's complete. Excuse me. Complete ultrasound requires the liver, the gallbladder, common bile duct, pancreas, spleen, right and left kidneys, the upper abdominal aorta, and the IVC. If any one of those elements is left out, then you have to code a limited. If you code document 8 of those elements and you leave out the IVC, the doctor doesn't document the IVC, that's now a limited exam. If he doesn't say why the IVC could not be seen. Again, 2 abdominal quadrants is still limited regardless of what the policy, the code description says, and 76705 is coded, and it's only coded one time. We get questions all the time about appendix, and there's no one way to code for that. It depends according to this ACR Q&A, it depends on what was ordered, the clinical condition of the patient, and what you actually imaged in the exam. The question was, how would an appendiceal ultrasound be coded? And the answer was, coding for an appendiceal ultrasound is in large part dependent on what was ordered by the referring physician, the clinical circumstances, and how focused the clinical question is. There are other abdominal abnormalities that mimic appendicitis, and it may not be proper to always perform a limited study. Therefore, when an appendiceal ultrasound is ordered and a limited right lower quadrant study is performed, a limited abdominal ultrasound code is reported, 76705. When a complete abdominal ultrasound is ordered and performed, report code 76700. When a pelvic ultrasound is ordered and performed, report code 76856. So if you ask me this question or send me this question, I'm going to send you this Q&A, so keep it handy. How to code for an appendix ultrasound really depends on what was ordered and what you actually did. Retroperitoneal ultrasound, 76770 is the complete, 76775 is the limited. The complete ultrasound, 76770, has two different definitions. If the clinical indication is urinary tract pathology of some kind, then a complete retroperitoneal requires only evaluation of both kidneys and the urinary bladder. For other clinical indications, 76770 requires evaluation of both kidneys, the abdominal aorta, the common iliac origins, and the IVC. Urinary tract pathology is, they have to be specific about that. They can't just, back pain is not necessarily urinary tract pathology. Back pain, rule out. Kidney stone would be urinary tract pathology. So you have to be careful with the documentation. The doctor needs to understand that he needs to be specific, that he's talking about a urinary, that they are looking for something in the urinary tract. Okay, going on to pelvic ultrasound non-OB, 76856 is the ultrasound pelvic non-obstetric complete. 76857 is the limited or follow-up. For a male, 76856 requires evaluation and measurement of the urinary bladder when applicable, evaluation of the prostate and seminal vesicles if they can be visualized, and examinations of any pelvic pathology. For a female, 76856 includes evaluation and measurement of the uterus and adnexal structures, measurement of the endometrium, measurement of the bladder when applicable, and a description of any pelvic pathology. Code 76856 is a transabdominal exam, though it does not say that in the code definition. It is transabdominal. Limited code 76857 may be transabdominal or transvaginal. For instance, it may be reported when a repeated follicle evaluation is performed using the transvaginal ultrasound. A bladder-only study with or without post-void residual is coded 76857 when imaging is performed. If post-void residual measurement is calculated without imaging, then that's code 51798. That's not usually going to happen in the emergency, in the radiology department, because normally you're going to do imaging. That may be done in the emergency room. It may be done in a doctor's office, or even up on the floor for an inpatient. But generally in radiology, you're going to do the imaging, and so it would be 76857 if it's a bladder-only study. The guidelines state that for complete 76856, evaluation and measurements of the bladder are required when applicable, and the seminal vesicles when they can be seen. you still have to document that. If you can't get the measurements of the bladder, or they are not applicable, or if the seminal vesicles cannot be seen, the doctor must document that in the report, or you have to code a limited exam. Okay, OB versus non-OB. If your order is pelvic ultrasound, it could be either. It could be an OB or it could be a non-OB exam that's necessary. You need to clarify that with a referring physician if he just orders pelvic ultrasound. According to the AMA, as published in the CPT Assistant in October of 2001, and this is still quoted anytime you ask the AMA or the ACR, they refer you back to this CPT Assistant from 2001. If the patient is known to be pregnant at the time of the ultrasound, at the time of the order, with symptoms that could be pregnancy-related, you code OB regardless of the findings. So if they have pain, they've had a positive pregnancy test. They may have had a positive pregnancy test at home. They may have had it in the doctor's office, but they are known to be pregnant. And if they have pain, that could be pregnancy-related, so you code OB, even if you do the ultrasound and there is no gestational sac. On the other hand, if the patient is not known to be pregnant, you code the non-OB ultrasound regardless of the findings. Again, a story from my past life. In a previous job, I worked in an emergency room. I was a clerk in the emergency room, and we had a young girl come in over the weekend. She was a freshman at college, and her parents brought her because she had been having abdominal pain, lower abdominal pain, pelvic pain, and the clinic at the college could not find out what was wrong with her. So they talked to her doctor, and he said, bring her into the emergency room. They brought her in. Everybody asked her, are you pregnant? Could you be pregnant? The nurse asked her, the doctor asked her, oh, absolutely not, cannot be pregnant. They ordered a pelvic ultrasound, and she was 8 months pregnant. That ultrasound would be coded as a non-OB, even though she was found to be pregnant, because there had been no pregnancy test performed, so she was not known to be pregnant. So you have to know what was known before the exam to know what you code, whether you code it as OB or non-OB. Generally, there is only one complete ultrasound can be coded per pregnancy, additional exams, or follow-up exams. And clinical examples in radiology, which is co-published by the AMA and the ACR, and is another really good resource for you, had a Q&A in the spring 2016 issue. The question was, a radiologist is questioning the use of the follow-up obstetric ultrasound examination, CPT code 76816, and when to use it. The radiologist feels that if an exam is performed during the first trimester, a complete examination should be coded even if the patient has had an earlier exam. If during the first trimester a complete examination is done as a follow-up to a previous study, is it necessary to build a follow-up code? As stated in CPT Professional Edition 2016, page 449, Code 76816 describes an examination designed to reassess fetal size and interval growth or reevaluate one or more anatomic abnormalities of a fetus previously demonstrated on ultrasound. Therefore, if a complete examination is performed to reassess fetal size, interval growth, or previously demonstrated anatomic abnormalities, one must report CPT code 76816, ultrasound pregnant uterus, real-time with image documentation follow-up, e.g. reevaluation of fetal size by measuring standard growth parameters and amniotic fluid volume, reevaluation of organ systems suspected or confirmed to be abnormal on a previous scan, transabdominal approach. So that statement, by the way, that it says as stated in CPT Professional Edition 2016, that statement is still in the CPT book today in 2020. So even if they've done a complete ultrasound, if they do another complete ultrasound to check the size or anything else to follow up from the previous, it is still a follow-up exam, and you code 76816 and not another complete ultrasound. So look at all of the OB ultrasound codes. 76801 and 802 are the first trimester codes for the first or single gestation, and then for each additional gestation. The required elements that must be imaged and documented are determination of the number of gestational sacs and fetuses, gestational sac fetal measurements appropriate for the gestation, younger than 14 weeks, 0 days, survey of visible fetal and placental anatomic structure, qualitative assessment of amniotic fluid, volume, gestational sac shape. Qualitative means the physician just has to say that is adequate or inadequate. Examination of the maternal adnexa and uterus and adnexa. The ACR radiology coding source, which is a free online newsletter on the ACR website, in April 2007, said when the pregnancy is in the first trimester, less than 14 weeks, the coder should remember that the required elements for CPT code 76801 will be those that are appropriate for gestation and visible. If any of the elements listed in the CPT book are not able to be measured or are not visible, then the report should document that information in order to assign 76801. If any of the elements are not documented, the limited OB ultrasound study should be assigned. The doctor can say it's too early to visualize XXX. But remember, when you do a later complete ultrasound, when those elements are visible, you would have to code 76816, not another complete ultrasound. So it's something you might want to think about. If it's too early where you can't visualize something, you might want to code that as a limited exam so that later on when you are able to do a complete ultrasound, you're able to code that one complete. You're going to get a limited one or a follow-up either way, so just think about that when you're coding them. You cannot code two completes. 76805 is the after the first trimester OB ultrasound code, transabdominal approach, single or first gestation. 76810 is each additional gestation. The required elements for these two codes is determination of the number of fetuses and amniotic chorionic sacs, measurements appropriate for gestational age, survey of intracranial, spinal, and abdominal anatomy, four-chambered heart, the umbilical cord insertion site, placenta location, amniotic fluid assessment, and maternal adnexa. 76801 is special codes, 76811 and 76812 are special codes. Ultrasound pregnant uterus, real time with image documentation, maternal and fetal evaluation, plus detailed fetal anatomic examination, transabdominal approach, single or first gestation, and 76812, each additional gestation. These are not for routine exams, even if this is your routine protocol. These are only for patients at high risk, level 3 high risk. Usually they will be ordered by a maternal fetal practice, and I have seen insurances deny them if they were not ordered by a maternal fetal specialist. So be careful there. Generally, they will only be performed once per pregnancy. 768, 11, and 12 require all of the elements of 76805 and 76810, plus a detailed anatomic evaluation including all of the following: the fetal brain and ventricles, the face, the heart outflow tracts, chest anatomy, abdominal organ-specific anatomy, number, length, and architecture of the limbs, detailed evaluation of the umbilical cord and placenta, and other fetal anatomy as clinically indicated. If I see a report that is coded as 76811 and it goes down this list of things and it's just normal, I'm going to question that 76811 because, one, normal is not a detailed anatomic evaluation. And if everything is normal, was that 76811 needed to begin with? So depending on the diagnosis, maybe it did. But these elements, these extra elements, need to be detailed anatomic evaluation. So be careful there before you code 76811 or 76812. 76813 and 14 are the codes for the fetal nuchal translucency measurement. 76813 is for the single or first gestation. 76814 is each additional gestation. Can be done from either a transabdominal or a transvaginal approach. It may be coded with other OB ultrasound codes if both are medically necessary, ordered, performed, and document. And it should be documented separately in at least separate paragraphs. You should have separate headers. And again, both should be ordered. It shouldn't just be routine. 76815 and 76816 are limited and follow-up, and they're a little bit confusing. 76815 is ultrasound pregnant uterus, real-time with image documentation, limited, e.g. fetal heartbeat, placental location, fetal position, and or qualitative amniotic fluid volume, one or more fetuses. 76816 is ultrasound pregnant uterus, real-time with image documentation, follow-up, reevaluation of fetal size by measuring standard growth parameters and amniotic fluid volume, reevaluation of organ system or systems suspected or confirmed to be abnormal on a previous scan, transabdominal approach per fetus. 76815, the intent is to do a limited scan or documentation does not support a complete ultrasound. 76816 is a follow-up of possibly abnormal ultrasound or elements unable to be visualized on a previous ultrasound. 76815 could be, like we said, the fetal heartbeat, placental location, fetal position, or the amniotic fluid volume. One or more fetuses, it doesn't matter. You code it once per exam, not per element or per fetus. If you have twins, if you have triplets, etc., you're just going to code 76815 once. 76816 is the follow-up. It's a reevaluation of the fetal size. It's a reevaluation of a suspected organ system that the previous scan looked abnormal. It's imaging of fetal anatomy not well seen on the previous study. This code 76816 is reported per fetus. You add a modifier 59 for each additional fetus. 76817 is the transvaginal code. It's ultrasound pregnant uterus, real time with image documentation, transvaginal. Per ACR, when this code is used in the first trimester, the same anatomy described in 76801 should be noted for this study. It can be coded with other OB exams if a transabdominal and a transvaginal are both performed and documented. Document each separately in at least separate paragraphs, each with its own technique. What was seen transabdominally and what was seen transvaginally. We see this all the time where they're just all jumbled together and you can't tell. Well, the problem is the regular ultrasound, transabdominal ultrasound codes all have specific required elements. If you cannot tell what was seen transabdominally, then how do you know that all of those elements were seen transabdominally? You're going to have to code a limited transabdominal exam in that case because you cannot tell what was seen transabdominally. Your doctor should document transabdominal ultrasound and what was seen, what was imaged, and what was found on the transabdominal, and then another paragraph or another page transvaginal exam and tell what was seen through there so that the appropriate codes can be reported and you don't have to document a limited transabdominal because you can't tell what was seen transabdominally. 76818 and 819 are the fetal biophysical profile codes. 76818 is with non-stress testing, and 76819 is without non-stress testing. You should have, it's a point system, 8 out of 8 for the non-stress testing code, 76819, or how many out of 10 points for the with non-stress cosine 76819. However, that the points are not enough. That can't be the whole report. 8 out of 8, 6 out of 8, 10 out of 10, etc. Documentation, it must include more than just the number of points. They must document fetal breathing movement, tone, trunk, and extremity movement, and the AFI. And you code for each fetus for whichever of these tests that you do, and you put a modifier 59 on the second, third, fourth, etc. If you haven't seen a fetal biophysical profile, this is what's tested, and how many, the points, they get 2 points if it's normal and 0 points if it's abnormal, and that's what you add up to the 8 or the 10 points in the exam. But again, they need to document about the movement and the breathing, etc., not just the 8 out of 8 or whatever the points are for that particular test. The CPT book has the following parenthetical note under 76819. For amniotic fluid index without non-stress test, use 76815. That's been a problem for years. It does not mean that you can code 78618 and 76815 if 76815 is only performed for the amniotic fluid index. According to the ACR, the amniotic volume determination is an integral part of the biophysical profile. This can be derived by measuring amniotic fluid in 4 quadrants or the single pocket measurements. Either of these measurements is included in the biophysical profile. Therefore, it is inappropriate to report 76815 in addition to 76819 if 76815 is limited only the determination of amniotic fluid volume. We wrote to the ACR about this several years ago because techs kept telling us, well, for the biophysical profile, we don't, we just get the single pocket measurement. We don't get the 4 quadrants. We measure it differently for the biophysical profile than for an ultrasound, and they were wanting to code 76815 in addition to the biophysical profile because they measured it differently, and if they measured the full way, that they would normally for an ultrasound, they thought they should be able to code for the ultrasound. You can't do that. Amniotic fluid index is part of the biophysical profile, and no matter how you get that index, it's included, so you can't code a limited ultrasound just for that. Now, if you do other imaging, if an OB ultrasound is ordered and is medically necessary and something other than the AFI is documented, then you can code an OB ultrasound with the biophysical profile. But it's got to be more than just the amniotic fluid index. Okay, diagnosis coding pointers for OB ultrasound. For screening, you're going to look at your Z36. There are a lot of additional codes in the Z36 area. These are some of the most common ones you would use in radiology. Z36-9 encounter for antenatal screening unspecified, or Z36-82 encounter for antenatal screening for nuchal translucency, or Z36-87 encounter for antenatal screening for uncertain dates. Do not code Z33-1, which is pregnant state incidental, unless the doctor specifically documents that the pregnancy is incidental to why an exam is being done. If a previous ultrasound or other imaging test is abnormal, but without a specific finding, report a code from the O28 section category of ICD-9, such as O28.3, abnormal ultrasonic finding on antenatal screening of mother, or O28.4, abnormal radiologic finding on antenatal screening of mother. For suspected field conditions affecting management of the pregnancy, you use the O codes out of Chapter 15 in the ICD-10 book. Okay, coming out of the OB ultrasounds, going to ultrasound elastography, 76981 to 76983 are those codes. Ultrasound elastography of any area. While ACR states that a regular ultrasound may be separately reported if performed prior to or after an ultrasound elastography procedure, CMS has CCI edits that prohibit coding both. So you need to look at what was ordered. Was the ultrasound elastography ordered, or was the diagnostic ultrasound ordered, and then based on the results, an elastography exam was ordered? And that needs to be documented if that's what happened. Coverage, at the time that I put together this PowerPoint, First Coast and Palmetto GBA consider ultrasound elastography as non-covered exams. So you want to check with your MAC and other policies for other insurances to see whether this is covered or not. 76981 is ultrasound elastography parenchyma, in other words, the organ. 76982 is the first target lesion. 76983 is each additional target lesion. If an organ is evaluated, not specific lesions, and here we're looking at the degree of fibrosis within an organ, if just the organ is evaluated, you code 76981, and it's once per organ. If they're looking at both the organ and the lesion within the same organ, you report 76981. If individual lesions are evaluated within one organ, report 76982 for the first lesion, 76983 for additional lesions. Now, 76983 may be reported for a maximum of 2 times per organ, regardless of the number of lesions you actually evaluate. These codes require imaging. For shear wave liver elastography without imaging, you report code 91200 instead of 76981 to 83. That's the FibroScan if you are doing FibroScan for liver elastography, that's 91200. Contrast enhanced ultrasound. We have two codes for this for the last couple of years. 76978 is targeted dynamic microbubble sonographic contrast characterization, non-cardiac initial lesion, and 76979 is each additional lesion with a separate injection. Special microbubble contrast agent is used at this time. Lumason is the only contrast material that is FDA approved for this. So generally that's what's used. You would not report an administrative code for the contrast material. The ultrasound can be used to characterize lesions, most commonly in the liver, the breast, the testicles, and the kidney. Probably the liver is the most common. Lesions are generally discovered on a non-contrast ultrasound performed at a separate session, and that ultrasound is reported separately. And again, there are CCI edits prohibiting coding of the regular ultrasound with contrast-enhanced ultrasound at the same session. So you want to be sure that if you do both at the same session, want to make sure that you have the order, you have the medical necessity for doing both, that you didn't already do a diagnostic ultrasound a few days ago or a week ago, and are just repeating that. And you're going to have to use a 59 modifier, and if audited, if this happens too often, you will be audited. So be very careful if you're billing a regular ultrasound with the contrast-enhanced ultrasound. Report 76978 for the injection and ultrasound of the first lesion evaluated. If you evaluate a second lesion after a second injection of contrast, then you report 76979 in addition to 76978. You would never report 76979 without 76978. Again, you don't report an administrative code such as 96374 for administering the contrast. That's included in the codes 76978 and 79. There are currently no LCDs regarding contrast-enhanced ultrasound, so you want to watch your local MAC for draft LCDs. Contrast-enhanced ultrasound is also being used to evaluate vesicoureteral reflux in children. This is not an evaluation of specific lesions, so it's a problem for coding. The codes 76978 and 79 are specific to lesions. Check with your payer to see if they want you to code that or to code something else. The first time we asked AMA, they told us that it may be appropriate to code 769, 78, and 79. Then the ACR answered some questions about it, and they said to code 51600 and 74455, which are radiological codes, not ultrasound codes. So we asked ACR again, and actually a couple of times, and then the first time we asked after ACR had published theirs, then they quoted the ACR 51600 and 74455. We asked them again, and they said, well, 76770 or 76775 could be reported for the ultrasound portion. We just really don't think they understand what's going on. And so the last option is to code for an unlisted ultrasound procedure. But really what we're telling everybody is check with your payer, preferably before doing the ultrasound VCUS, because you want to make sure you understand how to code it and how they want you to code it. When billing for contrasted enhanced ultrasound, the facility providing the technical component should also report the HCPCS code for the contrast material. Like I said, currently the only FDA-approved product is Lumison. The code for that is Q9950. It says in injection sulfohexafluoride lipid microspheres per milliliter. You report it per milliliter given. However, Medicare does allow providers to bill for discarded amounts of drugs, including contrast agents, from single-use vials and syringes of separately payable drugs. And Lumison is currently separately payable even for outpatient hospitals billed under OPPS. The discarded amounts must be clearly documented in the patient record. You would add modifier JW to the discarded amount, so you're going to bill the contrast on two lines. Lumison comes in a 5 milliliter vial. So if you give, for instance, 2 milliliters, you would bill Q9950 times 2 on one line, and Q9950 JW modifier times 3 on the second line. This is, if you want to bill for the discarded amounts, the JW modifier is required since January 1st of 2017. And I have a link there for you of FAQs concerning discarded drugs and the JW modifier. But like I said, Lumison is separately payable. Currently, it is for outpatient hospital under OPPS. It has pass-through status, and it's separately payable for imaging centers and doctor's offices. So you do want to bill both your given amount and your discarded amount. As I said, Q9950 has pass-through status, so it can be billed for the, it's paid under OPS, and you want to be billing both the given and the discarded amounts. Ultrasound bone density, 76977, is the regular ultrasound bone density. It's peripheral site, usually at the heel. That's the old code. We've had that for several years. 0508T is a newer one. It's pulse echo ultrasound bone density measurement resulting in indicator of axial bone density of the tibia. Bendex BI-2 device is the specific device that this code is for. Measurement site is at a third of the length of the proximal tibia to obtain the apparent cortical bone thickness. And then the Bendex software uses the cortical thickness measurement plus age, weight, and height of the person being measured to calculate the density index. 0508T, at the time I wrote the PowerPoint, Noridian said that they will cover it, maybe. They would send additional documentation requests to providers billing for that code, requesting specific documentation along with full text copies of peer-reviewed medical literature supporting the safety and effectiveness of the service for the medical director to review. CGS and First Coast listed as covered. Where covered, there's a payment amount for OPS, but under the, which is $112.08, but under the Medicare physician fee schedule, it's carrier determined, so there are no documented payments nationally. You have to look for your Medicare contractor. Okay, breast ultrasound 76641 is unilateral complete. 76642 is unilateral limited. Both codes are unilateral, so if you perform bilateral ultrasound, you're going to report it with modifiers LT and RT, or once with modifier 50, or with a quantity of 2 as per your payer guidelines. Complete ultrasound 76641 requires examination and documentation of all 4 quadrants of the breast plus the retroareolar region. Documentation can be by quadrant, upper, outer, lower, inner, etc., or by the clock position. However, ICD-10 CM codes are by quadrant. Limited ultrasound 76642 is anything less than a complete exam. Both include examination of the axilla when performed. If they're imaging the axilla alone without the breast, then it's coded as a lower extremity code 76882. For screening ultrasound of the breast, you want report 76641 or 76642 as applicable, and then the appropriate ICD-10 screening code. There is no screening CPT code for screening breast ultrasound. The Z1239 is other screening for breast cancer. That would be your primary code for a screening breast ultrasound. You can add R9022, which is inconclusive mammogram, which is used for when the patient has dense breast. Ultrasound performed because of dense breast without any other clinical indication is still screening, because dense breasts are normal. That's why mammograms are not performed on younger women, because their breasts are very dense, and it's too dense for mammograms to see through. As you get older, you get more fatty tissue in the breast, and then the mammogram can see through that to see if there are any masses or tumors. So it's a normal issue. So it's still coded as a screening ultrasound if dense breast is the only reason that the ultrasound is being done. Coverage will be subject to payer guidelines. Medicare fee-for-service does not cover screening breast ultrasound. You can look at www.rudenseadvocacy.org. They have an interactive map, so you can click on your state to see if there is an insurance coverage requirement for your state and what it actually says. There are about 7 or 8 states that do have insurance coverage requirements. Automated whole breast ultrasound is reported with the regular breast ultrasound codes 76641 or 42. Automated whole breast ultrasound is intended to be a screening exam, so you should use the screening diagnosis code with that. This is the SEER quadrants of the breast from the U.S. National Institutes of Health. The codes are not complete ICD-10 CM codes. These are the ICD-10 codes used for death certificates, etc. So you need to look in ICD-10 to get the whole codes, but they will tell you, this will help you if your doctor documents by clock position or even by quadrant, but especially if he documents by quadrant position, this will help you to know what codes. The nipple is coded as C50.0, and you would need to look for the right or the left. The central portion is C50.1, and there are additional codes for left, right, etc. I had a case the other day that a coder disagreed with me because the doctor documented as the central portion of at 7 o'clock, and she wanted to code C50.5 for 7 o'clock. And I said, but the doctor said central portion at 7 o'clock, so it's going to be C50.1. So these will help you. There's one for the right breast, one for the left breast. So when your doctor documents either by clock or by quadrant, you will know which category to go to. You know C50.2 for the upper inner quadrant of the breast, etc. And you can go to the ICD-10 book, ICD-10-CM book, to get the complete code for left breast, right breast, etc. ICD-10 codes for lump, mass, nodule, like I said, are by quadrant, not by clock position. Causes a problem when your doctor documents by the clock. You can code dual diagnosis codes if they document a mass at 12, 3, 6, or 9. You can document two quadrants. CMS on their Medicare NCD for mammograms said that dual diagnosis codes depicting specific quadrants can be reported instead of unspecified quadrants if found more appropriate by the provider. However, it would be easier if you can let your doctors know that the diagnosis codes are by quadrant, and it would be helpful if they would document by quadrant and not by clock position. Non-invasive vascular exams. We have two new codes this year for duplex scan for arterial inflow and venous outflow for preoperative vessel assessment prior to creation of hemodialysis access. It's 93985 and 86. 93985 is for a complete bilateral study. 93986 is for a complete unilateral study. These two codes replace G0365, and you would not report one of these codes, 93985 or 86, and 93990 for the same extremity. 93985 and 86 include evaluation of the adequacy of extremity arteries or veins before creating an arteriovenous fistula. For the veins, you're looking at patency, diameter, location, branching pattern, scarring, thrombosis, etc. For the artery, you're looking at diameter, calcification, location of the brachial artery bifurcation, for instance, if they're looking to put in an arm graft. They can be used to evaluate upper or lower extremity arteries and veins. They can be used for first-time AVFs or redo mapping. Can still be reported if the findings show that the AVF can't be created. So if you do this exam and there's too much scarring or calcification or whatever, and they say that they cannot use that arm for an AVF, you can still report the exam because you did the exam. These codes require both arterial and venous evaluation. If you only evaluate the arteries, then you're going to be looking at codes 93925, 26, or 93930 or 31. If only the veins are evaluated, you're going to be looking at 93970 or 93971 instead of 93985 and 86. If a physiologic arterial evaluation is also performed, it may be separately reported. It should be separately ordered as well. So we'll look at those 93922, 93923. These are not just an ABI. And the doctor shouldn't call them an ABI. This is an ABI plus. There is no code for just an ABI. The CPT guidelines book says ankle brachial index is reportable with 93922 or 93923 as long as simultaneous Doppler recording and analysis of bidirectional blood flow, volume plus thermography, or transcutaneous oxygen tension measurement are also performed. Medicare says ABI is included in the examination and not separately billable. Most states have an LCD that covers 93922 and states an ABI is not separately reimbursable procedure when performed by itself and would be considered part of the physical examination. You want to look for your own LCD in your state to see what they say about that, how they say that. These are just the code definitions. They're very long. They're very detailed because they tell you exactly what's needed. So you need an ABI plus either a bidirectional Doppler waveform recording and analysis, or an ABI plus volume plus thermography, or an ABI plus transcutaneous oxygen tension measurements, or for 93923 only an ABI plus provocative functional maneuvers. 93922 is an evaluation of one or two legs bilaterally. However, if only one arm or leg is available, you would report 93922 with a 52. If only one arm or leg is available, you would report 93922 without modifier 52 if three or more levels are documented or if provocative functional maneuvers are performed. 93923 is an evaluation of three or more levels bilaterally unless you're doing provocative functional maneuvers, and then only one level is required. If both upper and lower extremities are evaluated, you report the appropriate code twice with modifier 59 or XS. January 14th, CPT assistant had a Q&A, says what's the appropriate code to report non-invasive vascular testing performed without an ABI. TPT guidelines list ABI as a requirement to report 93922, 23, and 24 when non-invasive vascular diagnostic studies are performed. Therefore, if the testing is performed without an ABI, the unlisted code 93998 should be reported. 93924 is basically the same thing as 93922 or 23, except it's performed twice at rest and after treadmill stress testing. It's for the lower extremities only. It's not for the upper extremities. It does require motorized treadmill stress testing, not just walking. So if you don't have a treadmill, a motorized treadmill, then you won't be able to code this to report this code. Additional requirements for documentation: the ABI should be performed immediately after and at timed intervals during the exam. Should be a recording of time at onset of claudication or other symptoms, the maximal walking time, and time to recovery. CPT assistant in August of 2009 said, can 93924 be reported in cases in which the patient is unable to walk on the treadmill and the clinician decides to substitute an alternative exercise such as rocking forward on the toe or toe raises? And again, like I said, no, it has to be a treadmill. 93975 and 7 duplex scan of the arterial inflow and venous outflow of abdominal, pelvic, scrotal contents, and or retroperitoneal organs, complete study and a limited study. Both 93975 and 76 require performing and documenting both color and spectral Doppler as well as grayscale imaging of the vascular structure as opposed to imaging of the organs in the 70,000 codes. These are duplex scans. All duplex scans require grayscale imaging of the vascular structure, color Doppler, and spectral Doppler analysis. All duplex scans require those. Complete for a duplex scan means evaluating an organ in its entirety, including the inflow and outflow vessels and major vessels supplying the blood flow to the organ or providing its venous drainage. 93975 requires a complete study of the vascular flow of one or more organs in the abdomen or the retroperitoneum or both of paired organs. If only one of paired organs is evaluated, then you code a limited exam. A complete study of the liver would be coded 93975. A complete study of the liver and the pancreas would still be 93975 just once. However, a complete study of only one kidney would be the limited 93976 because it's a paired organ. If only the arterial flow of the organs is evaluated or only the venous flow is evaluated, then you've done a limited study and you would code 93976. So a renal artery duplex scan would be 93976, not 93975. When 93975 or 76 may be reported with 70,000 codes for abdominal, retroperitoneal, or pelvic ultrasound, when medically necessary, when ordered, should not be added routinely to every exam. If it's not specifically ordered by the patient's treating physician, the radiologist must document why it was medically necessary for the individual patient and document findings from the study. In a non-hospital facility, we recommend obtaining an order from the treating physician because of the Medicare ordering rules. A modifier is necessary to bypass edits if you code a 70,000 ultrasound code and 93975 or 93976. The decision to do a duplex scan in addition to a regular ultrasound is a decision by the ordering physician or the radiologist, not the technologist. If you don't have a specific order, the radiologist must be the one to decide to do that. It can't be done by, shouldn't be done by protocol. 93978 and 79 are duplex scan of the aorta and IVC, iliac vasculature, or bypass grafts. Complete study 79 is unilateral or limited study. Since they are duplex scans, again, you must have both color and spectral Doppler as well as grayscale imaging of the vascular structure. These are, the description says are, so you have all of the elements or just one of the elements. A complete evaluation of the abdominal aorta would be 93978. Complete evaluation of the abdominal aorta, IVC, and the iliacs would still be 93978 just once. Complete evaluation means that the entire intra-abdominal and or pelvic course of the vessel is evaluated. If only a portion of the vessel is evaluated, then you report the limited codes. If 93975 is performed, it includes the aorta, so do not report 93978 or 79 again for the aorta. Soft tissue ultrasound. Only two codes specify soft tissue. Those are 76536 for soft tissues of the head and neck, and 76882 for soft tissues, for the limited joint or other non-vascular extremity, which can include soft tissues. For other soft tissue imaging in other areas, the ACR ultrasound coding guide and the CPT assistant have published recommended codes, and we've included those for you here. The non-vascular extremity ultrasound, the regular extremity ultrasound codes, 76881 and 882. 881 is complete joint. It's got, you should document the joint space, the periarticular soft tissue structures, the complete joint. 76882 is a limited of the joint or any other non-vascular extremity structure. And again, that could be your soft tissue, could be just the nerves, just the muscles, etc. For 76881, it requires an examination of the joint space, the periarticular soft tissue structures surrounding the joint, such as muscles, tendons, and other soft tissue structures, any other identifiable abnormalities, and dynamic and stress images may be included. This is a listing from CPT Changes 2011, which is a book that the AMA publishes each year to discuss the new codes and the rationale for the new codes, and give examples of the new codes. And in 2011 is when 76881 was, the code description was changed. And they gave this example of, for 76881, for the ankle, you would need to document, image and document all of these structures to be able to code the complete 76881 for the ankle. So there's a lot that needs to be seen and documented before you can code the complete joint code. Non-vascular extremity ultrasound 76881 is 882. Permanently recorded images are required, as with all ultrasounds, along with a written report containing description of all the required elements or reasons why the required elements could not be captured. If you can't do all of the required elements, again, just like everything else, then you report the limited exam. Medicare has set an MUE value of 2 for both codes. The MAI is 3, which is date of service clinical. So the MAC can override the limit of 2 if medical necessity is proven. If you do both upper and lower extremities, for instance, that should be very rare. But if there is a need to do that, then you would you might be able to get payment for more than 2 if medical necessity is proven. However, if what you're doing is multiple joints for an arthritis survey, then you would report an unlisted code and not 76881 or 882, because that's not what those codes are for. Some tips for the extremity ultrasound. The evaluation of a mass within the soft tissues is 76882. Ultrasound of the axilla, when performed alone, is 76882. The spectral Doppler and color Doppler imaging evaluation is medically necessary and performed. You would report that in addition to 76882. However, your doctor needs to document why the duplex was performed and what diagnostic information was obtained from it. According to NCCI edits, 76881 and 882 are components of 93925, 26, 93930, and 31. If you have medical necessity, you can code both, but you would have to add modifier 59 to 76881 and 882 when appropriate. Question, what is the correct code for an ultrasound of the inguinal mass that is found to be an inguinal hernia? This is from Clinical Examples in Radiology, summer of 2014. And says the correct code for a mass located below the level of the inguinal ligament is code 76882. Depending on the location of the hernia, other code options may be 76705 for a hernia into the abdominal wall, 76857 for a hernia below the level of the iliac crest into the pelvic wall. 76936 is also an extremity ultrasound, but it's a specialized procedure / ultrasound. It's ultrasound of guided compression repair of arterial pseudoaneurysm or arteriovenous fistula, and it includes diagnostic ultrasound evaluation, compression of the lesion, and imaging. So after a heart cath or angiogram, the patient has a swelling at the access site, and they do imaging, whether it's 76 regular grayscale or duplex imaging, to see if it's a pseudoaneurysm or an AV fistula. If it's determined to be the pseudoaneurysm or the AV fistula, then pressure is applied using the ultrasound probe, and the thrombosis occurs to correct the abnormality. And that code 76936 is reported if you do the compression repair, and again, it includes diagnostic ultrasound evaluation. You would not report 76882 or 76881 or 93925 or 26 or for having done the diagnostic evaluation. If you do the evaluation and the pseudoaneurysm is not present, and so you don't do the procedure, then you code 93926 if you've done a duplex, or 76882 if you do a grayscale based on the doctor's documentation. 76937, ultrasound guidance for vascular access requiring ultrasound evaluation of potential access sites, documentation of selected vessel patency, etc., etc. The code tells you everything you need. It's an add-on code for most vascular procedures. It's not limited to central venous access procedure by CPT guidelines. However, some payers do limit it to that. Do not report it with 3327475, 3656869, 3657273, 36584, 37191, etc. You can read all of those that you cannot use code it with. It has a 5-part list of requirements. All are required before this code may be assigned. And this is all described in the code description. But the ultrasound must be used to evaluate potential access sites. This may involve ultrasound of multiple areas to see which site is most amenable to placement of the catheter. The dictated report must include documentation of the patency of the artery or vein that is selected for entry. Ultrasound must be used for real-time visualization of the vascular entry. It's not appropriate to code 76937 if you just find the vessel, mark it by ultrasound, but you don't use ultrasound to actually guide the needle entry. There must be documentation of the localization process in the medical record. This is usually included within the surgical procedure report. And there must be permanent recording of the chosen vessel. It's not required that the interpreting physician actually document that permanent images are recorded. However, doing so would reduce or eliminate the need to provide copies of those images for an audit. I know coders and I know auditors who will not code, who will not allow 76937 if the fact that permanent images were recorded or not is not in the report, because I've never had anybody, when I've done an audit, send me the pictures that show that prove that was done. When all five documents must be performed, coders, you're going to look for numbers 2, 4, and possibly 5. Documentation such as patent, narrow, or tortuous arteries or veins would fulfill the documentation requirements for number 2, the patency. Visualization of needle entry to the artery or vein must be documented in the report. IVUS 37252, 37253 for non-coronary vessels. These codes describe intravascular ultrasound. The probe is inserted within the blood vessel and images are obtained. 37252 describes the initial non-coronary vessel imaged. 37253 is each additional. IVUS includes any transducer manipulation and repositioning within the specific vessel being examined during a diagnostic procedure or before, during, or after the therapeutic procedure. You only code it once, not how many times you go into that vessel. you report 37253 for each additional vessel separately imaged. If there's a bridging lesion that goes from one vessel to the other and they image that with IVUS, then you're only going to code it for one vessel. If there are separate lesions, then you would code for two vessels. In the CPT book, particularly this year, they've done this for a lot of codes, but for IVUS, there are notes under 37253 that list the codes that 37252 and 253 may be assigned with. If it's not, the code you're using it with is not in that list, you can't code it, those codes together. And they did that, they've always done that in the CPT book, but this year in particular, they've added that to a lot more codes. So if you look in the CPT book, there are a lot of codes that have that code with or do not code with list under a code. CCI information, specific to ultrasound or non-invasive ultrasound. We have the link there for you. There are 13 chapters plus an introductory chapter. It says physicians must report services correctly. The manual discusses general coding principles and principles more relevant to other specific groups of HCPCS codes in other chapters. Codes representing services denied based on NCCI PTP, which is what we normally call CCI, may not be billed to Medicare beneficiaries. So if you get a CCI edit, you cannot bill for the patient, and you cannot provide an ABN and use that to be able to bill the patient. A lot of the policies in the book say physician, but unless otherwise indicated, that actually means not just physicians, but practitioners, hospitals, providers, suppliers, etc. The only time it doesn't mean, for instance, hospital, is if the rule doesn't apply for them. For instance, anesthesia rules do not apply to hospitals. And so if the anesthesia policies, it says physician, physician doesn't mean hospital. But in most cases, if it says physician, then it means it can also be hospital, etc. CPT versus CMS, the NCCI policy says physicians should follow the CPT manual instructions unless CMS has provided different coding or reporting instructions. The AMA publishes CPT Assistant, which contains coding guidelines. CMS does not review nor approve the information in this publication. In the development of NCCI PTP edits, CMS occasionally disagrees with the information in this publication. If a patient utilizes information from the CPT Assistant to report services rendered to Medicare patient, it is possible that MACs may use different criteria to process claims. Chapter 9 is the section for radiology sections for services. You can look at these. You can actually go to the NCCI policy manual. You should keep that handy anyway. These are all in Chapter 13. This one, abdominal ultrasound examinations, CPT code 76700, 76775, and abdominal duplex examinations 93975 and 76 are generally performed for different clinical scenarios, although there are some instances where both types of procedures are medically reasonable and necessary. In the latter case, the abdominal ultrasound procedure CPT code should be reported with an NCCI associated modifier. There's the ordering rules. They've been out there for many years. Hopefully you're familiar with them if you work in a non-hospital imaging center or doctor's offices. These ordering rules are not applicable to the hospital. They are applicable to the IDTF, doctor's office, etc. You have to be very careful with these because you're not allowed to order additional tests except for in an extreme situation. Okay, there are some codes in here, cases in here. We're not going to have time to go over them, but I do have the codes for you so that you can use them for your reference. I do have a code that I want to answer, a question that I want to answer. What needs to be documented for abdominal pelvic duplex flow or spectral findings, or both? You need both. You have to have you should have imaging because you need grayscale imaging of the vascular structure. So you should have something in there that indicates that imaging was taken of the vessel, whether it's an artery or a vein or both. You should have your color flow should be documented. You should have your spectral analysis documented. And you need all three of that before you can code a duplex scan. If they have only arterial flow documented, again, then you're going to code limited. If they have only venous flow documented, you're going to code limited. If they don't code all three, the imaging plus the color flow plus the spectral analysis, then you report it as an unlisted code 93998. Okay, we're just about out of time. Time for Laura to follow up with her instructions.
All right, thank you, Donna. Now, this next set of instructions are for our on-demand